Hello, I'm Steve Buck, Chair of the Department of Psychology here at the University of Washington. The lecture you're about to see is part of our annual Alan Edwards Psychology Lecture Series. Professor Edwards was affiliated with the Department of Psychology for half a century until his death in 1994. He was an outstanding teacher, researcher, and writer who introduced new statistical techniques that are credited with changing the way modern psychological research is conducted. Alan also permanently enhanced the intellectual climate of UW Psychology by endowing the Alan Edwards Lectureship, which since 1999 has brought an impressive list of renowned psychologists to the UW campus to interact with faculty and students. Now, the annual Alan Edwards Psychology Lecture Series presents the excitement of psychological research and its tangible benefits to both local and national audiences. The lecture you're about to watch is one of a pair given back-to-back that matched a UW Psychology faculty member with a visiting researcher to talk about a topic of great public and scientific interest. Good evening. I'm Steve Buck, Chair of the Department of Psychology here at the University of Washington. Welcome to this evening's continuation of the Alan Edwards Psychology Lecture Series. This series is presented by the Department of Psychology, the College of Arts and Sciences, and the University of Washington Alumni Association, and is funded by a generous endowment from Alan Edwards. The topics in this series illustrate how psychological research serves humanity. The University of Washington receives more research support money than any other public university in the country, topping $1 billion this year. The Department of Psychology alone receives over $11 million annually in research funding that helps us advance our knowledge of basic science, directly serve people in our community and around the globe, and train our undergraduate and graduate students. Tonight's lecture addresses the psychology of blink, understanding how our minds work unconsciously. Our speaker is Dr. Lisa Cooper. Dr. Cooper is Professor of Medicine, Epidemiology, and Health Policy and Management at the Johns Hopkins University School of Medicine and the Johns Hopkins Bloomberg School of Public Health. She earned an MD degree from the University of North Carolina at Chapel Hill and an MPH degree from Johns Hopkins, where she has been on the faculty since 1994. Dr. Cooper is an internationally recognized physician and public health researcher who was named a MacArthur Foundation Fellow in 2007, an award given to only a handful of people each year in recognition of their extraordinary accomplishments, creativity, and promise. Dr. Cooper's scholarship on communications between patients and their physicians is improving medical outcomes for minorities in the United States. Her research has identified the crucial role race and ethnicity play in the physician-patient relationship, influencing communications between patients and physicians and the clinical decisions made by the physicians. Toward this end, Dr. Cooper has developed culturally tailored educational programs designed to improve the diagnosis and treatment of hypertension and depression among African Americans. She's testing these programs in clinical trials funded by the National Institutes of Health. Please join me in welcoming Dr. Lisa Cooper.
Well, thank you for that introduction, and it's good to be here to talk to you tonight about race relationships and disparities in healthcare. So first, I'd like to give you an overview of what I plan to cover this evening. We'll start out with some definitions of a few key words, talk a little bit about disparities in health and in healthcare, and specific dimensions of healthcare quality, how those are categorized and conceptualized, and then we'll look at a few studies of healthcare structure, process, and outcomes and how they're being used to help us understand disparities. And then we'll conclude with some implications for research, for education of health professionals, for clinical practice, and for health policy. So just to make sure we're all on the same page, there are many definitions of race, but for the purposes of this talk, when I mention the word race, I'll be talking about a group of people who are united or classified together on the basis of common history or geographic distribution. And a disparity is basically a difference or a lack of equality. So racial and ethnic disparities in health have been extensively documented, and there are many potential reasons that this problem exists. Scientists have actually been studying this for over 100 years, and they believe that the reasons for disparities are quite complex and that there are several interactions among these factors. So these include biologic factors, socioeconomic status, which includes things like educational background and income and wealth and education, environmental factors, exposure to discrimination, cultural and health behavioral risk factors, and also access to care and quality of care, which may differ across racial and ethnic groups. And this diagram basically shows that there are several factors that may contribute to differences in health outcomes for individuals of different racial and ethnic backgrounds. And if you look over in the corner here, you can see that barriers may be personal or family-related barriers for patients, or they may be structural or financial barriers in the healthcare system. And these barriers impact upon a person's ability to use services, upon the quality and the type of care that they receive once in the healthcare system, also called mediators, and then ultimately on their outcomes, which include things like health status, equity of services, and patient views of care. And in recent years, researchers and policymakers have become particularly interested in the role of the quality of providers in terms of how those factors influence patient outcomes for individuals belonging to different racial and ethnic groups. In particular, when we talk about quality of providers, we've become interested in this field at looking at cultural competence, communication skills, and not only medical knowledge and technical skills, but also bias and stereotyping behavior by providers. And in fact, the Institute of Medicine published a report, a landmark report in 2003 called Unequal Treatment, which documented that differences in quality of care between individuals who were Caucasian or ethnic minority were not due simply to clinical appropriateness, need, or patient preferences, but rather were due to systems and legal and regulatory problems, as well as issues related to discrimination, bias, and clinical uncertainty and problems in communication between patients and providers. And they coined the term disparity to describe this problem that is seen in US healthcare. This report also documented what many of us had speculated upon for a long time, that racial and ethnic health care disparities are also pervasive. These differences in care across race and ethnicity are documented for conditions, across numerous conditions, across populations, includes children as well as elders, immigrants as well as non-immigrants, across settings, including primary care as well as specialty care, levels and types of care, as well as dimensions of healthcare quality, suggesting that there are some underlying factors that are common across all of these situations that might be contributing to the disparities. So when we talk about healthcare quality, what we like to do is to think of it in terms of the different categories of factors that contribute to healthcare quality. They may be considered as being part of the structure of healthcare, which is the characteristics of the settings in which care is delivered. They may be part of the process of care, which is the care itself or the activities that are undertaken by the healthcare system, or they may be the outcome or the effect of the care on the health and welfare of individuals or populations. Here are a few examples of structure, process, and outcome variables. An example of a structural variable would be the race concordance, or the match in race or ethnic background between the health professionals and the patients who are coming to receive care. Also, staff expertise, availability, organization, and coordination of care would be considered to be structural variables. Process of care variables could be considered to be either in the interpersonal realm, the technical realm of health care, or the appropriateness of care, which is basically care that we know to be effective at improving quality of life or health outcomes. And then finally, outcomes, which could be considered as falling into a category where patients actually rate their experiences, whether we actually look at whether services are delivered in an equitable manner, or whether or not we look at actual health outcomes, which include things like death rates or complications. So what do we know about disparities in process of care? For technical care, there have been numerous studies that show that ethnic minorities receive fewer preventive services, diagnostic and therapeutic tests and procedures, and fewer appropriate medications. But for patient-centered or interpersonal care, there are relatively fewer studies. And the few studies that have been done show that ethnic minorities rate interpersonal care from physicians that they receive more negatively than whites. And until recently, it's been unclear whether this is due to racial or ethnic discordance between patients and providers, to poor communication, to bias and stereotyping behavior among providers, or to mistrust among patients, or a combination of this and many other factors. Additionally, very few disparity studies have actually made links between these structure, process, and outcome measures. So the first study that I'll tell you about actually makes a link between a structural measure, race concordance between the doctor and the patient, and an outcome which is called patient ratings of participatory decision making, and I'll tell you more about that in just a minute. But first, what is concordance? A little bit more about that. It's a structural dimension, as I mentioned, of healthcare quality. It is thought to be shared identities between patients and health professionals. And why do we care about this? Well, mostly we care about this because most ethnic minorities see physicians who are different from them in key social characteristics. So patients and physicians may be concordant in visible demographic factors such as race, ethnicity, age, gender, language, social class, or education. Or they might be concordant on less visible factors such as beliefs and values, expectations, and preferred roles. My colleagues and I wanted to understand whether or not physicians who saw patients who were similar to them with regard to race and gender would have patients rate them as being more in partnership with them. So to do this, we conducted a study that is called a cross-sectional telephone survey, which basically means we called people at one point in time at home on the phone. And the individuals we called were 1,800 adults who had all seen their primary care physician within the preceding 2 weeks. And our sample included 784 whites, 814 African Americans, and 218 individuals who were Asian American or Hispanic. And they were only grouped together that way because we had too small numbers of each of those ethnic groups to look at them separately. And basically what we did was we went to these primary care practices in the Washington, D.C. area, and 32 of them agreed to participate in this study. And then we agreed to, the physicians agreed to have us contact their patients after the visit and to ask them questions about how the visit went. And as I mentioned, we were most interested in looking at race or gender concordance or discordance in the doctor-patient relationship and how it related to the patient's rating of the doctor's participatory decision-making style. So participatory decision-making style is measured by asking the patient to respond to 3 questions. If there were a choice between treatments, how often would this doctor ask you to help make the decision? How often does this doctor make an effort to give you some control over your treatment? And how often does this doctor ask you to take some of the responsibility for your treatment? And each question contributes 33.3 points for a total of 100 points overall. A higher score on this scale means that the doctor was more participatory with the patient. What we found is that ethnic minorities rated their visits with physicians as less participatory. As you can see on this slide, white patients rated their physicians 77 on a 100-point scale on average, whereas minority patients rated their physicians 74 overall. And this was true, this was statistically significant. And also, although it only seems like a small amount, like maybe a 4-point difference or a 3-point difference, what we've seen on this scale is that individuals who score 2 to 4 points lower on this scale are 10% more likely to disenroll from a practice over 1 year. The other thing we found was that when patients were seeing a physician of their same race or in a race-concordant relationship, they rated their physician as being more participatory. And you can see here that there is about a 3-point difference between the patients who were in race-concordant relationships versus those who were in race-discordant relationships. There's a similar pattern seen for gender concordance, but not statistically significant. And by the way, this finding was consistent among the patients of African American, white, and Asian physicians. And our sample size for Hispanic physicians was not large enough to determine whether it was true among that group. We then became interested to learn whether or not these patient ratings of care that differed in race-concordant and discordant relationships were actually due to differences in the interpersonal process. So were there actual differences in the communication that took place in the visit, or was this all due to just patient perception? Now, why did we want to look at communication? Well, numerous studies have shown that patient-physician communication is related to important outcomes. And these outcomes include things such as patient adherence or follow-up and continuity of care, patient satisfaction, as well as clinical outcomes. So we've seen in numerous studies that when the quality of communication is better among doctors and patients, that patients with diabetes have better glycemic control, that is control of their diabetes. Patients with high blood pressure have better blood pressure control. Individuals with chronic pain have higher rates of pain reduction, and those with depression have higher rates of resolution when they have good communication with their physicians. So we conducted another study in which basically we went to primary care practices and we collected pre-visit and post-visit surveys from doctors and patients, and also got permission to audio tape these visits. Our study participants included 458 African American and white adult patients who were receiving care from 61 primary care physicians. And these patients and physicians were in urban primary care practices that served managed care and fee-for-service patients. And the way we enrolled patients is that we had a research assistant go to these practices and basically approach patients as they came in for their appointments. And this took approximately 1 to 2 days to recruit approximately 5 to 10 patients per doctor for the study. But before we talk about how we actually measured this, it's important to understand what the functions are of clinical communication. So clinical communication has 4 important functions. The first is to gather data. The second is educating and counseling of patients. The third is relationship building. And the fourth, and perhaps most important one, is partnering with patients to negotiate diagnostic and treatment decisions. To measure the communication from audio tapes, we used a system of classification that has been well validated. It's called the Rotor Interaction Analysis System. And in this system, we have independent raters to listen to audio tapes. These raters are well trained and they're blinded to the study hypotheses. And what they're asked to do is to categorize every statement that is made by the doctor or the patient into one of 37 categories. The categories may be considered to be content related, such as biomedical information or psychosocial information. They can be affect related. This is all emotional related conversation, including positive and negative conversation. So things like compliments, laughter, and humor would be included here, as well as social or chit chat. And then finally, process-oriented conversation, which includes orientation statements made by the doctor about the flow of the visit, for example, or facilitation statements that are made in which the doctor tries to elicit the patient's opinion or get the patient to become more involved and ask more questions. So here are a few examples from the RIAS, or the Rotor Interaction Analysis System. For biomedical talk, the doctor might say something like, your blood pressure is 100/70, or the patient might say, I was in the hospital last year for ulcers. Psychosocial talk would be related to the patient's family or job, for example. So the doctor might say something like, you really need to get out and meet more people. Emotional talk, as I mentioned, would include statements of empathy or concern, for example, so this must be very hard for you. And partnership building, statements where the physician is checking to see if the patient is understanding what's going on, eliciting the patient's opinion. So do you follow me, and how does that sound to you? And in addition to the verbal conversation in the visit, the raters are also asked to rate the overall emotional tone of the visit. So basically, to rate the patient and the physician according to how assertive, how interested, how responsive, and how empathetic they sound towards one another. And for the doctor's affect score, the degree to which the doctor sounds hurried is actually subtracted from the overall score, because we know patients don't like it when doctors sound hurried. And basically, the way we conceptualize a patient-centered clinical interview is that this would be a visit where the visit duration was longer, where the speech speed was slower, where the physician is less verbally dominant, meaning that the ratio of all doctor to all patient talk would be close to 1, and that the patient-centeredness ratio would also be high. And a patient-centeredness ratio is calculated by adding up all of the psychosocial and emotional and partnership aspects of the visit and dividing that by the strictly biomedical conversation. And then finally, the patient-centered interview would be more patient-centered if there was more positive overall emotional tone by the doctor and the patient. So what we found here is that physicians communicate differently with Black and white patients. For this measure called physician verbal dominance, you can see here that physicians talk 73% more than Blacks and only 50% more than white patients. In terms of the overall emotional tone, independent raters rated doctors as sounding less friendly, less enthusiastic, and less responsive with their Black patients. They also rated the Black patients as sounding less interested, less enthusiastic, and less responsive in their visits. And then finally, the patient-centeredness ratio, which I described to you earlier, was also lower in the visits of Black patients than white patients. This was true regardless of the race of the physician. So it didn't matter whether the physician was the same race as the patient or not. It appeared that minority patients had poorer communication with doctors overall. We wanted to know what happened if there was race concordance in the doctor-patient relationship. And what we found is that the race concordant visits were longer, they had slower speech, and more positive patient emotional tone. So you can see here that the race concordant visits were about 2 minutes longer on average, that the doctor and patient both spoke more slowly, and that the independent raters rated patients as sounding more friendly, more responsive, and more enthusiastic when they were seeing a physician of the same race. The pattern was similar for physicians, but was not statistically significant. We also found, similar to what we had found in our earlier study, was that patients who were seeing a race concordant physician rated their physician better. So they had higher scores on participatory decision making. Their overall satisfaction rate was about 20 percentage points higher. And they were also more likely to say that they would recommend the physician to a friend if they were seeing a physician of the same race. This was true even after we accounted for the differences in communication that occurred in those visits. So, in summary, we found that African Americans in race discordant relationships with their physicians experienced lower levels of satisfaction and less participation in medical decisions, and also shorter visits with less positive emotional tone. We did find that differences in communication, however, did not explain why the patients in race discordant relationships rated their care worse. And this suggested to us that other factors such as physician and patient attitudes may play a role. We then became interested in examining to what degree there was bias in the doctor-patient relationship that could be contributing to these differences in patient ratings of care. So the next study that I'll describe to you is one that actually is currently being done and with some interesting applications. We'll be looking at race concordance and how it relates to reports of bias as well as patient ratings of care. So first, we'll talk a little bit about explicit versus implicit bias. So explicit or conscious bias are attitudes and beliefs that we recognize and we know we have, whereas implicit or unconscious bias include attitudes that are unavailable to introspection and outside of conscious cognition. These can unintentionally affect behavior and are actually better predictors of behavior than self-reported measures of prejudice, stereotyping, and discrimination. We're conducting a study to look at the relationships among clinician racial bias, communication behaviors, and patient experiences of care. Again, we're doing a cross-sectional study, which means we're measuring these reports at one point in time rather than looking at this over a longer period of time. Our study participants for this study include 42 primary care clinicians. These include physicians as well as nurse practitioners, and 225 of their African American patients. They come from 24 urban community-based primary care practices in Baltimore, Maryland, and Wilmington, Delaware. And for this study, our main predictor variables are the clinician's implicit attitudes about race, measured with the race attitude IAT, or implicit association test, and patient race associated with medical compliance IAT. And I'll describe these a little bit further for you. You may have heard a little bit about this in a previous lecture. So the race implicit association test is an indirect measure of an individual's implicit or unconscious attitude. Images appear rapidly on a computer screen, and subjects respond by sorting pairs of images and attributing using right and left keys. And the premise is that individuals will respond faster to concepts that are strongly associated compared to those that have weak associations. So in particular, if subjects match good plus white and black plus bad pairings faster than they match black plus good and white plus bad pairings, then the race IAT score differs from 0 and is positive, and this is labeled an implicit white preference. This test was developed by Greenwald and colleagues. So just to show you an example of what the computer screen looks like, an implicit preference for whites would be exemplified by a response to these pairings occurring faster than the response to these pairings. There's a new application of the IAT in which an implicit association between European American and compliance is examined compared to actually an association between African American race and reluctant patient. So you can see that the response, a pattern that would suggest a pro-white compliant patient bias would be demonstrated by a response to these pairings occurring faster than a response to these pairings. So what we did was we actually asked the physicians in this study to go online and complete both of these IATs. And at the same time, they had agreed to have us audio tape their visits with their patients and to have their patients complete surveys about the quality of care. We did have over a 70% response rate from the physicians to this. So our main outcome measures were, again, obtained by audio tape of the visit and included clinician and patient communication behaviors measured by the Rotor interaction analysis. And we also had patient ratings of care that included overall satisfaction, trust in the clinician, and the quality of interpersonal care that were all measured by a survey immediately after the visit. We wanted to examine whether clinicians' implicit attitudes predicted differences in communication and in patient ratings of care. The audio tape ratings were based on the emotional tone ratings that I described to you earlier. So clinician positive affect was measured as the average of 6 items, each rated on a 5-point scale, and these items included interest, warmth, engagement, respect, sympathy, and not hurried tone. Again, these were rated by independent raters, not aware of the study hypothesis. And then patient behavior similarly included the average of 5 items, each rated on a 5-point scale, include interest, warmth, engagement, sympathy, and respect. And then the patient ratings of the clinician, these were the questions the statements that we asked the patients to let us know their level of agreement with. So overall, I was satisfied with this visit. I would recommend this provider to a friend. The quality of interpersonal care included these statements. My provider has a great deal of respect for me. My provider likes me, and I like this provider. And then finally, trust. I trust this provider to act in my best interest. Again, the responses are on a 5-point scale from strongly disagree to strongly agree. Again, we had 42 clinicians who agreed to be in this study. They were about 44 years old on average and had been in practice for about 13 years. 64% of them were women, and 45% of them were Caucasian, with 21% being African American. You can see the majority of these clinicians consider themselves to have a liberal political ideology. Most of them are general internists, although the remainder were family physicians, and 90% of them were board certified. Now, interestingly, when we asked the physicians explicitly about their attitudes with regard to race and regard to the association between race and compliance, what we found is that most physicians in this sample actually rated themselves as having very warm feelings towards African American patients, actually warmer feelings towards African Americans than whites. And when asked to rate basically overall how cooperative they felt patients were of different races, they did express that they associated European Americans with being more compliant with medical care. So these are the characteristics of the patients who were in the study. They were about 55 years old on average. 80% of them were high school graduates. Most of these patients were women. This is fairly typical for primary care practices. They were all African Americans. Most of them had health insurance. You can see almost 90%. And about 60% of them actually had an annual household income of less than $35,000. So this was sort of a lower middle class, social class sample of patients. So what did we find? And this diagram may look familiar to those of you who saw a previous lecture. Our clinicians in this sample expressed a preference, had a pro-white bias. As you can see, 60% of the physicians in this sample had either a slight, moderate, or strong preference for whites on the race attitude IAT. And you can see that the most common category of rating was either a strong or, either a slight or moderate preference for whites. This is similar to what has been seen in larger samples of society. So this is a graph that's very similar that shows a response of over 700,000 respondents on a website called Project Implicit website, where the race IAT has been on that website for many years. And you can see that 70% of individuals in society in the United States express some sort of a preference for whites. So our physician sample seems to be comparable to larger samples of society. What we found here is, I just want to point out that in looking at the association of clinician implicit racial bias with the clinician's positive affect rating by an independent rater, just to let you know here that these negative numbers for the beta coefficient means that for each 1-point increase in the IAT score, indicating a more pro-white bias among clinicians, warmth, friendliness, interest, engagement, respect, and sympathy, and unhurried tone with African American patients was rated lower by independent observers. And this was true for both the race attitude IAT as well as the patient race medical compliance IAT. And in terms of the rating of the physician's implicit racial bias with the patient's positive affect, you can see a similar pattern here, whereby this negative beta coefficient means that for every 1-point increase in the IAT score indicating more pro-white bias among the clinicians, that African American patients were actually rated as sounding less friendly, warm, interested, engaged, respectful, or sympathetic by independent raters. And these findings are statistically significant. The other thing we found here is when we looked at the association of clinician racial bias with patient reports of care, this slide basically shows an odds whether the patient would strongly agree with these statements. And if the odds is less than 1, that means the patient has a lower odds of strongly agreeing that they were satisfied with the visit as the IAT score increased, or as the physician became expressed a more pro-white bias. And you can see that as the IAT score increases, the patients have less odds of saying that they were satisfied with this visit, this doctor respects me, this doctor likes me, I like this doctor, I trust this doctor, and I would recommend this doctor to a friend. So this pattern is consistent across all of the measures, and these lines that go horizontally here are basically confidence intervals around the measure. So this measure that crosses over 1 means that this is the only finding that was not statistically significant, but all of the rest of these findings were. This is a pattern that was shown for the race attitude IAT. There's a very similar pattern that was shown for the IAT that associates race with compliance. So in summary, this is the first study to explore links between implicit bias, clinician behaviors, and patient ratings in actual patient encounters. Primary care clinicians in this sample displayed implicit attitudes about race that are similar to those measured in large samples of society. And the implicit bias favoring whites and the association of white race with medical compliance predicted more negative clinician and patient emotional tone and poorer ratings of care by African American primary care patients. So what are the implications of these studies? Well, first, one of the implications is that there needs to be additional research to examine links upon clinician attitudes, behaviors, and health outcomes. There's very little work that actually looks at how physician attitudes actually predict behaviors and treatment. I think there's a widely held belief among clinicians that it doesn't really matter so much what you think as long as you are doing the right thing. And so I think that this would be very important in terms of informing health professional education. What can we do to apply some of this information to health professional education? One of the implications is that we need to employ more patient-centered communication skills programs. These are programs that will emphasize rapport-building behaviors and affective dimensions, and also enhance clinicians' awareness of their biases and their intercultural skills. In terms of clinical practice, this work suggests that it will be important to implement patient activation programs, particularly for minority patients who don't speak as much, don't ask as many questions, and may not feel as involved in their care. It also suggests that we need to improve scheduling and increase time for physicians and other health professionals to build rapport and develop continuity of care with patients who are different from them in terms of racial and ethnic background. And with regard to policy, this work suggests that increasing the number of underrepresented minorities among health professionals will help to increase access as well as patient experiences with care. This field has evolved over the last 30 years. So many of the initial studies in the 80s and 90s were spent on describing the problem, describing disparities in care. And then newer studies moved into understanding mechanisms, and I'd like to consider the study that I just described to you as one of those studies. And finally now, along with the Institute of Medicine report, researchers and policymakers are now calling for studies that actually design and test interventions to evaluate their impact on outcomes. So I've been involved in 2 studies, and I'm just going to describe them briefly to you. One of them called the Patient-Physician Partnership to Improve High Blood Pressure Adherence, a randomized controlled trial of 50 primary care physicians and 500 patients with high blood pressure in Baltimore. And what we've done is we've conducted communication skills training for these clinicians, which is done by an interactive CD-ROM program. And we've also assigned patients to receive patient activation by a community health worker. Now, our main outcomes are patient adherence and blood pressure control, but of course we're going to be looking at process measures like communication behaviors and patient experiences with care. And in another study called the Bridge Study, Blacks Receiving Interventions for Depression and Gaining Empowerment, this is another randomized trial of 30 primary care clinicians and 250 of their African American patients with depression, based in Baltimore and Delaware. And And what we'll be doing here is comparing a standard quality improvement program for depression to a more patient-centered, culturally tailored program. The patient-centered, culturally tailored program includes a communication skills training and cultural sensitivity training for clinicians. And our main outcomes for this study are depression remission, depression level, and guideline concordant care. Although again, we'll be looking at process measures such as doctor-patient communication and patient experiences with care. Both of these studies are funded by, the first study was funded by the National Heart, Lung, and Blood Institute, and this study funded by the Agency for Healthcare Research and Quality. So I'd just like to conclude with some acknowledgments to my numerous collaborators who make this possible. Dr. Rotor at Johns Hopkins, Drs. Greenwald and Sabin here at University of Washington, Dr. Tom Inouye at Indiana University, and Ms. Catherine Carson and Dr. Mary Catherine Beach at Johns Hopkins. And I'll stop there and take questions. Thank you.
Thank you, Dr. Cooper. Please move to the microphones for your questions. I have one right here.
Hi, yes, thank you for sharing your study's very interesting findings. I was wondering, have you done or are you considering to extend the study to look at other socioeconomic brackets as well as geographic regions? Okay, well, there are numerous studies that have actually already documented that independent of socioeconomic status, that race actually predicts quality of care. So that's already been shown in numerous studies. Whether or not this finding of bias in care and patient reports of it would differ for patients who are either upper middle class or lower middle class, we don't know that yet, but we can certainly explore that in this study. And depending on like the numbers of patients that we have in those different categories, we might be able to draw some conclusions, or we might actually have to wait until we get a larger study sample. But yeah, there is interest in looking at that. Yeah, that'd be interesting. My second part of the question was geographic regions. It looked like most of the studies were on the East Coast, and just out of curiosity, I wonder if there would be any differences if you looked at the West Coast, or certainly if Texas and California with higher Hispanic populations, what the results would be for those populations. Right, I think that would be very interesting. I think there are a number of studies that have been done actually nationwide that have shown similar patterns of disparities regardless of geographic area. There haven't been studies actually examining communication in this level of depth or clinician bias and patient experiences. So I've been studying Baltimore because that's where I am, and it's easier for me to do that. And actually it's fairly resource intensive to do this kind of study on a large scale, but I'm sure that as interest in the field grows, that we'll be seeing more studies in other areas of the country. Yeah, I wonder in a region also that's less diverse than DC, such as the Midwest, if you would see even greater disparities than what you saw. That's a very good point. In fact, these practices, for the most part, were practices where there was a fair mixture of patients of different ethnic backgrounds. So these clinicians actually have a fair amount of experience in dealing with patients from different ethnic backgrounds. So it does make you wonder if you go to a place where there is less diversity, whether this problem might even be more pronounced.
Dr. Cooper, I just had a question as far as some of the data, or if you did any survey about patient histories, like going through family histories that influence patient response. You know, talking about older African Americans and within families and generational perceptions of healthcare. Right. Did that influence or come into play in the study?
That's another very good question. And we have other questions that we did ask patients about their experiences in the healthcare system, whether they had previously experienced discrimination or whether they had known someone else who had done that. And we have rather low rates of people actually reporting that. But we certainly know that from other studies that African Americans and other minorities report less trust in physicians and in the healthcare system, and this is probably due to many historical factors. So, but to answer your question, we have some information about that, but again, not a lot of people in this sample. These are people, remember, who have a primary care doctor and have a relationship with them. And so a lot of them are not really saying that they've been treated with bias by this particular physician, but again, they're still reporting lower levels of trust and satisfaction, along the lines of according to how the physician scores on this test. So,
we have a question over here.
Yeah, towards the end you had mentioned cultural sensitivity training. Do you know of something on the East Coast on the West Coast where they're operating in that way? I don't know. It seems like that's really important, like that we could be a part of that kind of training as well. So I'm curious if you know of any local.
I think there's a lot going on at numerous medical schools right now. The national kind of accreditation organization, so things like the AAMC, the American Association of Medical Colleges, has now requiring cultural competency training for students. So there's a lot of work being done in this area, looking at different methods of providing people with these experiences, combining lectures with small group discussions, with kind of experiences out in the community, trying to see if increasing people's awarenesses of their own cultural background and their potential biases and how it might impact on how they interact with others, trying to see if that will enhance their behaviors when they actually interact with patients. But it's all sort of in infancy stages right now. But there are several medical schools where these types of curricula are being developed and evaluated.
Okay, thanks.
We'll go back over here.
Yes, communication was the focus, and that's fundamentally an interactive process. And was there some reason then that you didn't ask the patients to take the IAT? That would be, to me, a critical variable to rule out alternatives, explanations to that dynamic, or to shed light on better understanding the dynamic and the underlying mechanisms and potentially remedial kinds of activities for both doctor and patient.
Right. I understand your concern, and we've done a lot of things where we sort of measure from the patient's perspective and the doctor's perspective, knowing that this is a very interactive and reciprocal relationship. One of the reasons I actually did not ask the patients to take the IAT, it would have been logistically more difficult to do that, to have all of these people have access to the internet to do this test. The other reason I chose not to do this in this particular study is that I actually think because of the power dynamic in the doctor-patient relationship, that even if we discovered that patients had a particular bias towards the doctor's characteristic, like race or gender or whatever, that in terms of policy implications, that there was less that we could really do about that than we could do about actually impacting on doctors. I think doctors are in the decision-making capacity and in the power position in the doctor-patient relationship, and they're the ones who are determining whether or not patients get referred for tests or not. So, it's important to know that patients have biases too, but in terms of actually changing clinical practice or care, I felt that the first step needed to be on the part of the providers.
In this case, it was all about communication. And so I think it still would have been a very good thing to do. I understand the logistics part of it, but
I think it's
still,
scientifically an interesting question.
Yeah, thank you.
Okay. Have a question here?
I was kind of interested in the whole implicit association test in general, and I guess what caught my attention was as you're going through and talking about like the preference and the compliant or the non-compliant patient, were there tests also run on whether or not, because those words to me seemed like they were also positive and negative associations, were there tests also run if the people that perhaps put positive association, like those words, I guess the compliant words were all positive, and putting that also with the specific gender, and if that factored in, and if there was a test run, like I guess what were the results for that? Does that make sense?
I'm not sure I'm not sure I
So like, okay,
understand what
let me
you're
set
saying.
this up a different way. So basically we have, the preference for a specific gender. Like let's say, for instance, African Americans and whites, and then we have these, the compliant or non-compliant terms.
Mm-hmm.
To me, compliant words, they seem more positive. So if there's already an associated, like an implicit association of what we saw in the previous tests of, positive and white and negative and black, then what happens with the additional, like, I guess the compliant and non-compliant words? Does that
Right.
make more sense, I guess?
Yeah, I hear what you're saying. I think the test may measure something a little bit different. And I mean, they're certainly related to one another. I think that it has a potential to kind of impact more on clinical care than on, say, just a general preference for a particular race. If you have linked these two concepts in your mind, in terms of race and compliance, that could explain more of your actual, like, clinical decision-making than a more general preference or, lack thereof for a particular racial or ethnic group. So, and we have seen that although the patterns are similar for those two tests, that there are some subtle differences where one test is actually a more strong predictor of certain behaviors or patient reports. So for example, the association between race and compliance was a stronger predictor of trust among patients than it was of the other behaviors.
Dr. Cooper, I'm very excited to have you here. I'm interested in making a comment and getting your thoughts. I'm inherently skeptical about how well this very excellent research will be propagated and applied. I'd be very interested in seeing it applied. For example, I work at group health at physician attitudes in our system. As a physician relatively recently out of training, I think a lot of this to me is very much rings true because some of the scars from my training are still very present. And I'm interested in how well basically how well you're able to take this thesis and apply it on a national level when we have health disparities and we have a long history of basically blaming things besides racism. So we've had, for example, health disparities documented since the 1930s, late 1930s with American Dilemma, Gunnar-Myrdal, the large Gunnar-Myrdal study, which looked at everything with race in America. But one of the most interesting things it said is it really looked at the resistance that whites have to the idea of racism and the idea that in America we have this paradox where we want to believe in equality, but we can't actually manifest it. So one of I guess the first of the two reasons of skepticism is how do you get people to buy into a thesis that's essentially stating that we still have racism. And then the second thing is the second question and the second reason I'm skeptical is how do you actually change the minds of physicians? Because as a physician, I definitely know that you've seen and I've seen that it's very difficult to change physician attitudes, and the modus operandi is that everyone is doing it wrong except for myself. So I'm just curious about those two things. Thank you.
The not in my backyard phenomenon, yes. Well, this is going to be challenging, but I think, we talked a little bit about this earlier. One of the ways to look at this is that it is an adaptive way of behaving. It's a way that we process information, and it has nothing to do with whether you're a good person or a bad person. These are associations that we acquire through our early experiences, and that basically we engage in these things in an unconscious way. So I think if we can present it to people in that way and have them realize that this is what we do, and we tend to rely on this sort of level 2 processing when we are under stress and when we don't have enough time to sort of really use our conscious and our higher level thinking, that people will understand that this is, it's not a reflection of somebody's character or moral, values or anything like that. It's an unconscious thing, and that hopefully with awareness of it, that they can actually then engage in some sort of conscious behaviors to change what they do. They may not be able to change the unconscious attitude, but they might be able to change their actual behavior in certain situations. I think that there's some resistance to this idea, but I do think that the field of medicine has expressed an openness to examining the issue, and that at least the topic is now out on the table. And I don't think it's going to go away. I think we all recognize that the country is becoming more diverse, and that these kinds of issues are having a serious impact on our ability to deliver the best care that we can. So I don't think it's going to go away. I don't think it's necessarily going to be an easy thing, but I do think that we have a pretty substantial percentage of the healthcare force that is really kind of interested in this, concerned about this. We're collaborating with people in psychology, in sociology, to try to get a better handle on this and try to develop some interventions.
Okay, please join me once again in thanking Dr. Cooper.